From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
Hello and welcome to our listeners from around the world. I'm Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Myasthenia gravis is a rare autoimmune disease affecting the nervous system and skeletal muscle, resulting in muscle weakness. I'd like to welcome our author today, Dr. Kelly Gwathmey, who will be discussing the efficacy and safety of Gefurulimab in the treatment of generalized myasthenia gravis. Dr. Gwathmey is an associate professor of neurology at Columbia University, and she is also the vice chair of the Medical and Scientific Advisory Council with the Myasthenia Gravis Foundation of America. Dr. Gwathmey, welcome to the podcast.
Thank you so much for having me.
Now, I wanted to give our audience just a little bit of a background here. Many of us are neurologists, but we're talking about myasthenia gravis, and we're getting right into treatment. But I wanted you to go over a little bit of pathophysiology that makes this relevant. When I think of this, I'm going back to my boards. I'm thinking complement. Tell us more about myasthenia gravis.
Yes, absolutely. So as everyone on this listening into this podcast knows, myasthenia gravis is an autoimmune disorder that results in dysfunction of the postsynaptic neuromuscular junction, right? And so what happens? So our body creates these autoantibodies that bind to the acetylcholine receptors that results in cross-linking and endocytosis, and then we're basically pulling those receptors off the postsynaptic membrane. So that's part of it. But the second part of it is that with the binding of the antibodies to the receptor, it triggers this complement cascade, right? So what happens is C5 is activated, results in the terminal complement cascade and the formation of this membrane attack complex on the postsynaptic membrane, which punches holes in it, and then results in damage and simplification of the postsynaptic membrane and inefficient neuromuscular transmission as a result. And that is why we've been very interested in inhibiting complement going way back to 2017 when eculizumab was approved for generalized myasthenia gravis with acetylcholine receptor antibodies, or AChR antibodies. And so it continues to be a really attractive therapeutic target in myasthenia gravis.
That is excellent. Now, tell us about the current treatment landscape.
So in general, we think about myasthenia gravis in a number of different ways. Just very briefly, we think about in terms of the distribution of the symptoms, so ocular myasthenia gravis versus generalized myasthenia gravis. Today, we're talking about generalized. So that means that the patients have fatigable muscle weakness outside of just the eye muscles alone. And so we think about that too in the context of what treatments are available. So a lot of the newer therapeutics are labeled specifically for generalized myasthenia gravis. So I would say that first of all. In terms of treatment too, we think about it in terms of our seropositive patients. Again, do you have AChR antibodies or maybe muscle-specific tyrosine kinase antibodies or MuSK? And then are you seronegative instead? You do not have any detectable autoantibodies on commercially based assays. And so understanding the patient you have in front of you in the room will really help guide you in terms of your treatment options. So today, still, I would say the algorithm for most patients is to start with pyridostigmine, acetylcholinesterase inhibitor, right? It's been around for many decades, followed by treatment of the immune system itself. And so a lot of us continue to start with a low dose or moderate dose of a corticosteroid because it works relatively quickly, and then transition patients over time to a non-steroidal immunosuppressant therapy, such as azathioprine or mycophenolate mofetil. So again, going back to 2017, with the advent of this next generation of therapeutics that are more targeted, we have our complement inhibitors, of which we're talking about today. We have our neonatal Fc receptor antagonist, such as efgartigimod. And then more recently, we have an FDA-approved B-cell depleter, which is inebilizumab. Okay, that's a CD19 inhibitor. And so all of a sudden we have this therapeutic explosion. A lot of times we reserve these newer therapeutic agents for patients that have moderate to severe disease or have failed the more conventional, typical treatment algorithms.
And all of these treatments that have come out since 2017, how are they administered?
Eculizumab is an infusion. Ravulizumab, which is a longer acting version of eculizumab, both complement inhibitors, that is also an infusion. And then zilucoplan is a complement inhibitor that is a daily subcutaneous injection. We have efgartigimod that is available both as an infusion or subcutaneous injection. We have rozanolixizumab, which is available as a subcutaneous brief infusion. And then we have nipocalimab, also a neonatal Fc receptor antagonist, which is available as an infusion. And then lastly, inebilizumab is an infusion, the CD19 inhibitor.
So that takes me into our current study. Tell us more about the nanobody that you are looking into in terms of efficacy and safety.
So Gefurulimab, what makes it unique is it utilizes this nanobody-based platform. So what is a nanobody? It's a single domain antibody derived from the heavy chain only of the antibodies. And so it's a much smaller molecular size than your typical conventional antibody. And so what Gefurulimab really comprises of is two different variable domains of the heavy chain. One binds to albumin and one binds to C5. And its low molecular weight, small size, allows it to be injected. And so Gefurulimab was studied as a weekly subcutaneous injection, which differentiates it from ravulizumab and eculizumab, which are infusions. Now, also, the albumin binding results in extending the half-life of this therapeutic via that neonatal Fc receptor recycling pathway that has been utilized in other therapeutics as well.
Very awesome. I'm thinking about this and thinking about the lives of patients that may be changed in terms of how they're receiving these therapies, giving it to themselves, considering the outcome of this current study. Now, let us get into the setup. Tell us about how this study was designed and the main outcomes you were looking into.
Yes, thank you. So this was a large phase 3 international trial. So there were 113 sites over 20 countries. And this was a randomized placebo-controlled trial for 26 weeks and then followed by an open label extension period. So in terms of the participants that qualified for this trial, as I alluded to in the beginning, you needed to have generalized myasthenia gravis and you needed to have acetylcholine receptor antibodies. You also needed to have a moderate degree of disease severity. So we use the Myasthenia Gravis Activities of Daily Living scale, which is a subjective 8-item scale that really queries patients about how they're experiencing their myasthenia symptoms. So for example, there's an item about double vision, there's an item about ptosis. And so we add up the score. The higher the score, max score is 24. The higher the score, the more severe the disease. And so for the purposes of this trial, you needed an ADL score of 5 points or greater to qualify. Also, I'll say you could not have ocular myasthenia gravis. And so we think about how we grade the severity of myasthenia gravis by the MGFA classification. For this trial, participants needed to have a class of a 2, 3, or 4, meaning mild, moderate, or severe generalized disease. So our primary endpoint for this trial was the MG-ADL score at 26 weeks compared to baseline. The key secondary endpoint was the QMG. So that's the quantitative myasthenia gravis score. And what is that? So that is a much more objective, highly standardized, lengthy physical exam that is really tailored to looking for subtle weakness and fatigability in myasthenia gravis patients. And so this is not an outcome measure we routinely use clinically due to the duration of administration, but it's a very nice outcome measure in a clinical trial. And so that was the key secondary endpoint.
Yeah, so you're looking at nuanced differences along different key points of the study to see if there's progression or regression or improvement or so.
The key here, if you think about big picture, is we want to look at improvement from the patient perspective with the ADL, and that's again the primary, and then the secondary with the more objective physician administered examination, which is the QMG. And then there were a number of other additional secondary endpoints like the MG composite, which is a weighted examination that incorporates some questions to patients, things like that. So we did use the more standard endpoints that we use across MG trials here.
Now, what did you find?
Yes. So, in terms of the efficacy of Gefurulimab, we did find a statistically significant benefit in terms of the improvement on the MG-ADL score at 26 weeks compared to baseline in those treated with Gefurulimab. And so the difference in the score was 4.2 points on the MG-ADL for those treated with Gefurulimab compared to 2.6-point improvement in the placebo arm at week 26, which was statistically significant. So we saw also the same improvement on the QMG score as we saw on the ADL score. That was statistically significant as well. And then all of the secondary endpoints, looking at responder analysis, and again, the MG composite scale that I mentioned earlier, all of those met statistical significance as well. So pretty much across the board, we were very pleased with how this drug performed at week 26. But I think it's also really important to point out that this drug works quickly. As soon as week 1, the MG-ADL score was improving in patients that were treated with Gefurulimab. And then at week 4, which was the first time point that we got a second QMG, it already was showing statistically significant benefit. Gone are the days of waiting 12 months for a nonsteroidal immunosuppressive therapy to work, right?
That is amazing. How wonderful is that to tell a patient when they ask that question, because that's always one of the first questions. Safety, we'll talk about that next, versus how fast does this work is when am I going to see results? When am I going to see the benefits? And that's amazing.
Yes.
Now, safety. Were there any patients in the study that stopped the medication prematurely because of tolerance? Tell us about your safety results.
Yeah, so in terms of safety, Gefurulimab performed extremely well. I will say first, before we get to that, 7 patients in the Gefurulimab arm did require rescue therapy. So in MG trials, right, if patients have acute exacerbation or worsening and they need rescue therapy with IVIG intravenous immunoglobulins or plasma exchange, that's something we take into consideration. So 7 patients on the Gefurulimab arm compared to 16 on the placebo arm. So that I'll say first. And then in terms of common treatment emergent adverse events, it was really well tolerated. The most common things that were encountered in the Gefurulimab arm were injection site reactions, likely not surprising given as a subcutaneous drug, headache, and back pain and nasopharyngitis. And then really importantly, a question that gets asked and discussed all the time is whether or not there were any cases of Neisseria meningitis, right? So because it's a complement inhibitor, just like all the other complement inhibitors on the market, we need to vaccinate our patients against meningitis before initiating the therapy or at the same time generally. And so all of the participants in this trial were vaccinated against Neisseria meningitis before the trial, and then according to the local guidelines in terms of boosters, et cetera. And so there were no cases of meningitis during this trial.
Dr. Gwathmey, if you can tell our listeners, where do we go from here and what can we tell our patients? How do we counsel our patients? And what's next in this nanobody mechanism type treatment for generalized myasthenia gravis?
Thank you. Yes, I think the takeaway here is that Gefurulimab is a novel therapeutic that has a nanobody platform, again, that allows us to use it in a way that it's a weekly subcutaneous injection that provides the patient autonomy and flexibility in administration and provides a different option of how it can be administered. And, I think the trial clearly demonstrates benefit of Gefurulimab, similar to what we've seen with eculizumab and ravulizumab, but we see that it's working extremely quickly and that it's very well tolerated. We are so very excited to be sharing these results with everyone, and we hope that one day this treatment will be available to our patients with generalized myasthenia gravis.
This is excellent. I am also excited about the potential of Gefurulimab in our patients. Dr. Gwathmey, thank you so much for joining us today on the podcast.
Thank you so much for having me. And I would just like to thank the entire PREVAIL team, all of the site investigators, all of the participants in the trial, as well as the team at Alexion for supporting this study.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.